we can get started now. Good afternoon, everyone. My name is Shirley Girouard, and I'm the CSG East Health Policy Consultant. And I bring greetings from Senator Gustavo Rivera from New York State, who's unable to join us because he has to deal with a major public health issue hearing today, and that is in housing. So he does send his greetings, and we will be following up with all of you after this session and working with Health Committee on some of the issues that get raised today. Today's format is webinar, so you are muted. If you'd like to raise a question or make a comment, you can put your question or comment in the Q&A box. You can also raise your hand by using the icon that's at the bottom of the page. This session really highlights a lot of issues that I know many of our states are grappling with. Probably all of them are grappling with around the health of the public and public health. And as highlighted by the pandemic, these issues have really come to the fore and raised some real challenges for all of us in the roles that we play in relation to states and state government. So I'm delighted to have with us today a distinguished speaker, Arnon Parekh. Dr. Parekh is the Bipartisan Policy Center's Chief Medical Advisor, who provides clinical and public health expertise across all aspects of the organization. He leads their policy responses to the COVID-19 pandemic. Prior to joining the center, he was the Deputy Assistant Secretary of Health at the U.S. Department of Health and Human Services, has been involved with implementation of the Recovery Act's Prevention and Wellness Fund and the Affordable Care Act. Earlier in his Health and Human Services career in the United States government, he was the Secretary's Special Assistant and Science Advisor. He's a board-certified internal medicine physician, a fellow of the American College of Physicians, an adjunct professor of health management and policy at the University of Michigan School of Public Health, and an adjunct professor of medicine at Johns Hopkins University. His book, Prevention First, Policymaking for a Healthier America, was released in December 2019 and argues that prevention must be our nation's top health priority. So please join me in welcoming Dr. Parekh. You can put up your slides, please.
Great. Can you see them now?
Yes.
Great. Wonderful. Shirley, thank you so much for that kind introduction. It's great to be with all of you today. I want to thank CSG for convening us and CSG's leadership. And I want to thank everybody who is on this Zoom call. Thanks for your public service and your efforts during these continuing difficult times. I wish we were in a better spot with respect to the pandemic. Unfortunately, we're seeing about 500 deaths every day across the country, preventable deaths, given that we have a vaccine, about 130,000 confirmed cases daily, which is an underestimate given our lack of testing capacity. We've made progress with vaccination, about 50%, as you know, of the public vaccinated, and 60% of adults, 80% of seniors. But we still have a ways to go, particularly with the highly transmissible Delta variant. So getting through this wave, it's going to be critical to continue breaking chains of transmission through distancing and masking and getting more people vaccinated, as so many are trying to do, and really tackling vaccine hesitancy. Public health is one of these things where I think over the last 18 months, there's been more appreciation about the role of public health. And I think that is good and that's important. There's also been opposition to some of the actions of public health. And therefore I think that this topic today is a pretty important one to take a step back and I think ask ourselves some important questions about what we want from public health, for our country in pursuit of improving health outcomes. So sort of welcome the opportunity to take a step back and broaden out the conversation from pandemics to broader issues related to public health. So trying to set the record straight and level set for all of us, I think where we have to start is the purpose of public health, which is really to assure the conditions that populations can be healthy. Now, that being said, if you look at sort of surveys of the American public and you ask the public, what do these two words mean, public health? Oftentimes you get a shrug of shoulders, or you say, well, people might say, well, isn't that Medicare, or isn't that Medicaid, or isn't that health insurance, or isn't that community health centers? And the answer is no. I think, as we all know, public health is not those things. There is some indication that the understanding of public health is improving. There was a recent poll sponsored by the Robert Wood Johnson Foundation and the Harvard Chan School of Public Health in Boston, and they looked at a 25-year span between 2021 and 1996. And in 1996, 25% of the public said that when they heard public health, they knew what that term meant very well. 51% said somewhat well. In 2021, it's 42% saying that they understood what that term meant very well, and 44 somewhat well. So potentially there's a little bit greater understanding about the role of public health. Of course, you have to really dive into exactly what people might think about when they hear public health. But certainly, I think we can all say that the pandemic has increased some overall appreciation. It's also important to recognize that the main cause of life expectancy increases in the 20th century were not due to sort of my profession, sort of the medical profession. They were due to public health. So the average life expectancy from 1900 to 2000 increased 30 years, from 47 to 77. It's estimated that 25 out of those 30 years were due to public health. You think about sanitation, and you think about antibiotics, and you think about healthier lifestyles. So I think that's really counter to public perception. And CDC now twice in 2000 and then in 2010 sort of listed out the greatest achievements for public health over the last decade, as well as over the last century. And really, this is really the answer to public health. When somebody asks, well, what is public health? What does public health do? Why is it important in this country? Why should we consider it as sort of part of our nation's infrastructure? This is what public health does: vaccinations, control of infectious diseases, motor vehicle safety, safer workplaces, helping to get to declines in deaths from coronary heart disease and stroke, recognizing tobacco as a health hazard, ensuring that our food is safer and healthier, ensuring that mothers and babies are healthier, and family planning, fluoridation of drinking water, lead poisoning prevention, cancer prevention, public health preparedness and response. So public health is really a set of activities focused on a wide variety of areas, as you see here, everything from communicable disease control to chronic disease prevention to maternal and child health to environmental health, again, to assure the conditions that populations it can be healthy. And if that's sort of the what public health does, the next question is, well, how does public health do work in that space? And that's where these 10 essential public health services come from. The 10 services to protect and promote the health of all people in all communities. So what does public health do? It assesses. It assesses and monitors population health. It investigates. It communicates effectively to the public. So assessment comes first. Then it develops policy, strengthening and supporting, mobilizing communities, partnering, implementing policies, utilizing legal and regulatory actions. And then there are a number of assurance mechanisms. You want to ensure equitable access. You want to make sure you have a diverse workforce. You want to make sure you're evaluating so we know we're really achieving the outcomes we want. We need organizational infrastructure, all with equity at the center. So this is sort of the how public health tries to achieve health gains in all of the areas that I just mentioned. So going back to sort of the public's perspective on all of this, given what public health does and how it does it, this recent poll from RWJ and the Harvard School of Public Health asked the American public, essentially, do you believe that these types of activities are are important to the health of the United States. And 72% of the public, sort of a healthy majority there, believe the activities of public health agencies in the U.S. are extremely or very important to the health of the country. In fact, also a pretty healthy majority favor increased federal spending on improving the nation's public health programs. Now, this is also interesting, given that right now, what is, as you know, being debated in Congress and in DC is a massive infrastructure package. It's a bipartisan infrastructure framework, and now sort of a Democrat-focused infrastructure package, and a lot of focus on everything from roads and bridges and tunnels and water, and but you don't really hear the term public health very much, which is interesting. And I think many would argue that the same way we think of sort of the physical infrastructure in this country, shouldn't we also think about public health that way? You know, it's one of these things that we often take for granted. We never really think about public health until there's a crisis. And then there's a crisis and we say, hey, where's our public health system? And that is sort of one of the ways where, one of the reasons why I think that sort of looking at this as part and parcel of our nation's infrastructure is pretty important. And then there's some more data from the survey looking at the public ratings of public health departments and agencies. And here you see an array of public health entities, governmental public health entities, federal agencies, state agencies, local agencies, and then an overarching sort of nation's public health system. And what you see is over the last decade, you know, some disheartening numbers here, particularly if you look at the bottom one. There's an asterisk there because that's the one that's statistically significant. There is a drop in sort of the excellent and good rating of our nation's public health system from 2009, where it was 43%, to 2021, where it's 34%. And that also gets at maybe the underlying issues of trust, which I think you know, we've heard a lot about during the pandemic, and unfortunately there has been some polarization with respect to the public health system there. So there are issues here related to trust, related to understanding of the public health system, related to how do we focus more on public health, that I think are pretty important for our discussion later. I'm going to spend just a couple of minutes discussing two specific projects at the Bipartisan Policy Center. The first on sort of pandemics, because that's sort of the moment we're in right now, and I think everyone can understand how pandemic preparedness is a really important aspect of public health. But then sort of a second project that is broader than pandemic preparedness, which really gets at what is our vision? What should our vision be? Our 5-year vision for a governmental public health system in this country. Just for background, probably should have Shirley started this. Many of you may already know about my organization, the Bipartisan Policy Center. We are a nonprofit organization founded 14 years ago, founded by 4 Senate Majority Leaders, former Senate Majority Leaders, Tom Daschle and Bob Dole and Howard Baker and George Mitchell. The aim really is to bring all sides together to promote health, security, and opportunity. And the way we work is we take on really topical issues where there are policy windows, and we try to bring all sides together and put forward policy recommendations. We are federally focused, but as you can imagine, many of our recommendations are germane to localities as well as state. So one of our recent projects focused, the first one focused a little bit more on the pandemic space, and so that's why I'm going to mention that one first. This is from our Future of Healthcare Task Force that's led by former Senate Majority Leaders Bill Frist and Tom Daschle. And here the idea was, obviously we're in the midst of a COVID-19 pandemic right now, but we also need to be, as we're combating this pandemic, think about how we can be better prepared. What are the lessons learned over the last 18 months so that the next time this happens, and it's not a question of if, but when, unfortunately, how do we ensure that our public health system is prepared? And this effort was federally focused, but I think that there are a lot of impacts and I think important issues for states and localities as well. There really are sort of three sets of recommendations that our bipartisan task force came up with, particularly at the federal level. One, there needed to be much closer sort of intergovernmental cooperation. And so that includes sort of defining intergovernmental roles and responsibilities, clarifying and strengthening federal roles and responsibilities. That's everything from, how do we make sure that localities and states know who to work with? What is it when you work with FEMA and when you work with CDC and when you work with ASPR? We have our emergency management components at the state and local level working with FEMA. We have our health department working the local and state level working with CDC. We have public health emergency managers working with the Assistant Secretary for Preparedness and Response. A lot of interactions there between federal and state and local, but understanding and really delineating at the federal level roles and responsibilities will then also help states and localities understand how during a crisis like a pandemic, we're all working together. And particularly at the federal level, one of the recommendations there was actually for the president to appoint a deputy national security advisor for pandemics and biothreat preparedness. There's so many governmental agencies, as you can imagine, at the federal level involved in something like a pandemic response, that you really need strong White House coordination to bring all of these agencies together. There were also recommendations related to incentivizing states to participate in a coordinated response. Now, certainly every locality and state need flexibility to ensure that they are reacting to the situation on the ground. But we've seen many cases over the last 18 months when there were evidence-based guidelines where states and localities just weren't able to follow those, and how we ensure that we have a unified response while recognizing that you need to have built-in flexibility is, I think, something that the task force spent a lot of time on, and thinking through how do you incentivize states to participate in a coordinated response. There's also a recommendation, an oversight recommendation related to Congress establishing a national board on pandemic preparedness. You'll recall we have something like this for things like Medicare, Medicaid. Every year or so, you hear the headline, Medicare's going bankrupt, or we need to do something about Medicare solvency. And so there are trustees that are continuously assessing the fiscal solvency of Medicare and Social Security. In the same way, having a national board on pandemic preparedness that's independent, that establishes metrics for the federal government and states so that they can focus in on preparedness and capacities and capabilities, and then gauge how the federal government is doing, how states are doing against those metrics, and then issuing an annual report to Congress. We think the task force thought would be an important mechanism, an oversight mechanism the federal government could have to, again, ensure that locality, states, and the federal government have the capacity and capability to respond to the next pandemic. So a suite of recommendations in that space. There are also a set of recommendations related to the public health data infrastructure, which in this country is very antiquated. We think about healthcare and electronic health records still being behind the time and not interoperability. Public health is even a little bit more behind, where you have silos of public health data systems, and from locality to locality, state to state, for different functions, you have different data systems. The task force felt strongly that we need to establish federal data collection and reporting standards. We need to identify what does a core public health data set look like. We need to establish standards for that data set. We need to then ensure that those standards are implemented, tie it to funding as well as accountability. We need to improve data sharing and interoperability so systems can talk to one another. We need an integrated surveillance system. And we need to make sure EHRs are required to have public health data sets as well, so we can have public health and healthcare data exchange. And then we need to strengthen vaccination data systems. We don't have to have a federal vaccination mandate or credentialing system, but certainly federal government has a role to play to ensure that such a system can track, to at least ensure that information is kept private and information is secure and information is of high quality. So it's less sort of tracking and eavesdropping. It's more of ensuring privacy and ensuring that the data is of high quality. And then we need mechanisms by which our immunization registries can track vaccination status as well. which is really important, and have important information about subgroups of the population that may not be vaccinating or may be more vulnerable. We still aren't getting race and ethnicity data from many localities and states across the country. That's just sort of one example. And so we need better data to understand where there are pockets of those who are unvaccinated, so we can do a better job reaching out. And then finally, there were a suite of recommendations related to public health financing. In this country, we spend about $4 trillion on health. It's about 18% of our GDP. If you ask the question, out of that $4 trillion of our GDP, how much of that health expenditure goes to public health? It's not a quarter, it's not 10, it's not 5, it's less than 3%. It's about 2.5%, and even that's an overestimate. Most of that public health funding goes to federal activities and funding federal agencies. If you actually then ask how much actually goes to local and state public health, it's even less. So in this country, for an area that has so much responsibility in public health, imagine how little we spend on public health. And I think ultimately it's a question for all of us, because where we spend our resources define our priorities, and our priorities define our values. And so if the question is, how healthy of a country do we want to be? Then I think it's a fair question to ask, are we investing enough in public health? And so the task force felt that it was important to have a set of recommendations related to public health financing. And these recommendations related to everything from, for those mission critical federal programs, whether it's surveillance programs or stockpiling or developing new therapeutics as well as vaccines, that those mission critical federal programs for pandemic preparedness really ought to be exempt from discretionary caps and have its own permanent budget designation, because those are just vitally important really to our nation's interest in our nation's security. Also, recommendations related to public health emergency fund. Let's say there's a crisis tomorrow in the Northeast. It usually takes Congress a couple of weeks or months to pass supplemental packages to get emergency funding to these localities. We have a public health emergency fund. We've had one for decades. The problem is there's been no money in there. So really allocate funding to the public health emergency fund so you have a little bit of a stopgap in case there's a crisis. This third bullet is really important, allocating mandatory funding, so not discretionary, to support state, local, tribal, and territorial foundational public health capabilities. Our research has essentially showed that at the local and state level, there really aren't a lot of resources to support bread and butter foundational capabilities, surveillance, lab capacity, policy development, communications, data, and IT. And academic researchers have actually estimated the gap that it would take for every state and locality to achieve those foundational capabilities. It's about $4.5 billion annually. And so one of the recommendations from this bipartisan task force was to allocate mandatory funding to support state, local, tribal, and territorial foundational public health capabilities. And then finally, there is an existing what's called Prevention and Public Health Fund that's been there for over a decade or so that supports important public health activities as well as functions. And one recommendation was to revamp that fund and increase resources in that fund. Well, one thing that we found in terms of the pandemic, perhaps not surprisingly to many of you, that part of the reason why we've also had poor health outcomes with respect to the pandemic is our underlying health status of the American public is not that great. You only have to look at something like obesity, for example, where we have 4 in 10 Americans, adults who are obese, 2 in 10 children who have obesity. And it's actually many of these chronic conditions, from obesity to high blood pressure to heart disease to diabetes, that have contributed to hospitalizations from COVID. So if you want to have a more resilient public in the face of these crises, improving the underlying health status of the American public, preventing chronic diseases, managing chronic diseases when you can't prevent them in the first place, is going to be absolutely critical to reduce the morbidity and mortality from any crisis. So these are sort of a set of recommendations that the bipartisan task force came up with 3 buckets here. Intergovernmental roles, responsibilities, you got to know who's in charge. Public health data infrastructure, you want to have the data in a crisis so you know where you are and where you want to be. And public health financing, you need the resources to be able to respond. And so this was released a couple of months ago. We've had a number of briefings on Capitol Hill and the White House, and we've talked to federal and state and local partners as well. But we're happy to send you this report if it would be helpful to your work. The second Bipartisan Policy Center project I wanted to brief all of you on is now broader. So the really crux of, I think, today's session is pandemic preparedness is important, but public health, as we talked about at the outset, is so much more. And there needs to be sort of a communications plan, a better understanding for policymakers and the public about what public health is and how to enhance public health. And so BPC has formed a national partnership with a number of public health nonprofit associations, many of which you all work with. ASTO, the Association of State and Territorial Health Officials. So these are the state health officials. NACHO, the National Association of City and County Health Officials. These are local officials. The Big Cities Health Coalition, which are local health leaders from big cities. Many philanthropies from Pew Charitable Trust, the Kresge Foundation, to the CDC Foundation, to Beaumont Foundation, as well as the Bipartisan Policy Center. And the project that we have embarked on is essentially to develop a 5-year strategic vision to define a 21st century governmental public health system. What does it need to look like? And what is an actionable framework, with the key audience here being local and state elected officials, as well as frontline public health practitioners. And this actionable framework is really centered around a number of focus areas. The first, and none of these are probably surprising, the first, data infrastructure and information technology. We talked a lot about that a few minutes ago with respect to pandemic preparedness. This is even broader. This is everything from interoperability, healthcare and public health, bidirectional information flow, local, state, federal, having data to know that you're making health improvements for accountability perspective as well. Workforce capacity, we know over the last decade that the public health workforce has faced losses, tens of thousands of jobs lost in local and state public health. This is over the last decade prior to the pandemic. And we know the pandemic has simply exacerbated this. So workforce capacity, addressing equity, promoting racial healing and transformation. We have known for some time the tremendous health disparities, and these are disparities not only race and ethnicity, but they could be gender, they could be sexual orientation, they could be rural and urban, many different types of disparities, particular racial and ethnic disparities as well. So addressing equity, so that is front and center. Public health law and governance, that has been front and center, of course, during COVID-19 with respect to states and localities and exemptions and mandates and public health authorities. And unfortunately, we've also seen firing and threats to public health officials and the relationships between elected officials and public health officials. And so governance there, very, very important. Financing, and we've talked about that at length with respect to pandemic, but even broader, the importance of ensuring robust financing for public health. And then a sixth focus area looking at partnerships and community engagement. And this focus area is actually probably two separate things. You need partnerships with other sectors to ensure that the health of the public is optimized, whether it's the business sector or the housing sector, the nutrition sector, the transportation sector. Community engagement is related, but it's also something separate. And here the idea is public health needs to remember that it's not what you do for a community, it's what you do with a community, and understanding community needs, involving communities in the work of public health, being transparent, remembering that public health is made up of two words there. We often focus on the health part, but the public part, that first word, is as important, and meeting the public where they are absolutely important as well. So the idea was to really take these focus areas and come up with a set of actions for local and state elected officials and frontline practitioners in each of these areas that would support a 5-year strategic vision to define what a 21st century governmental public health system is. And we have been at this now for a couple of months. We are striving to ensure this isn't some sort of Washington, D.C. top-down process. And so all of the partner organizations are hosting town halls and focus groups. We have actually a request for information out right now to ensure that we hear from frontline practitioners, which we'd be happy to share with you. So we have surveys out. We are hosting in each of these focus areas roundtables. So we hear from national experts. We have a national public health advisory group as well. And then importantly, I think this is where BPC comes in, and this is what we often do. We have formed a bipartisan task force made up of former and current local and state elected officials, as well as a couple of representatives from a few sectors that are essential to public health work, whether it's the business sector or the faith community or the advocacy community or the healthcare community. And you'll recognize a number of the names here, a couple who are CSG members as well, or who are in the Northeast as well. But this is really a group that we hope will eventually take everything that we learn and help us with the framing, help us with the communication. Certainly public health needs to carry its water, but at the end of the day, the public's health is everyone's responsibility. And so having lawmakers, current and former, on both sides of the aisle at all levels, having the business community, the faith community, the healthcare community, various sectors also help elevate and uplift public health, I think is a core purpose of this effort. So even though the audience may be actions over the next several years for elected officials and frontline practitioners, I think given the polling data that I articulated early on, given what we know about what people think about public health, given where we are in our nation with COVID-19, this is also, I think, a fresh opportunity to convey what public health is all about, why it's important, and why we really need to support it. So this is an effort. I said the timeline is through November. So we hope by Thanksgiving to have a report as well as a set of recommendations. And we are more than happy to keep you informed there, and more than happy, Shirley, to seek feedback and input from CSG members as well. So let me just stop there. Those are just two, I think, important projects right now. One just completed on public health and pandemic preparedness. One that is in the works now, more broadly focused on public health and the future of governmental public health that the Bipartisan Policy Center is leading. But I hope this has been informative, and really looking forward to the discussion, the time that we have together. Thanks very much.
Thank you. We're starting to get some queries and some discussion in the chat, which we can talk about. One of the things that's come up from both one of the staff people at CSG and one of the participants, and I expect it resonates with all of us, is making sure that we get a copy of the report and the survey tools that we can distribute to our members. And we can distribute that broadly. So if you want to send those along, we will see that they get posted and sent out through our communication channels.
That sounds great, Shirley. We'll certainly send the first report and the request for information from the second project. Absolutely.
Right. And we can do that. One of the things that came up in a meeting that we had with our colleagues from Canada, we have a committee that talks about border crossings that I think would be of interest perhaps to some of the folks on the call from some of those border states, are the issues you talked about, the laws, and we talked about collaboration and partnerships. And with Canada, if you could speak to the issue about what's going on vis-a-vis border crossing in the United States and Canada, and allowing people to go back and forth. That did come up in one of our meetings, and the committee, I don't know the proper name of it off the top of my head, on territorial and state relations between the US and Canada, does have a resolution encouraging the federal government. And one of the things that they discussed is how do you get to the people that can address that issue?
Yeah, well, I can start by saying that, viruses obviously know no borders here. And so I think at the end of the day, when we think about the US or Canada or, border crossings and people coming in from one place to another, surely it comes down to bread and butter public health. And that is all about, vaccines. It's all about testing. It's all about sort of following public health guidance there. It's about breaking chains of transmission, masking and distancing. It's understanding at the local level where the borders are, what is happening on the US side, what is happening on the Canadian side, what does disease transmission look like? So I think you have to really get back to the basics of public health and assess the situation on the ground to make sort of those policy decisions about borders and whether it's the border, the northern border, or the southern border, or others.
Who could people in the states speak to in the federal government who might be able to assist with doing some of those things?
Yeah. When I was in the federal government, there were a couple of there was an agency that focused really on both sort of the northern as well as the southern side. So it was Canada, US, and Mexico. And they dealt with sort of border policy issues there more broadly. This was obviously much before COVID. I could try to find out exactly where that is. It may be with the Global Health Office at the US Department of Health and Human Services. But there is a group that focuses on those kinds of issues.
That would be great. Any inside information you can get to us, because that has not been successful so far. Other questions? People want to raise their hand or? Okay, Francis, go ahead and ask your question.
Thank you. I was just curious, during the pandemic, our public health agencies became really, really busy. They had to staff up to do contact tracing, to put vaccinations in place and all of this. In where I live, they had a hard time finding qualified people to do all of this. And I was wondering if, I'm from Northern Ontario, and I was wondering if it was the same in the different states.
I can start, and then perhaps others can give their thoughts from their vantage point. I think what I heard was really twofold. One is, as I mentioned, I think the public health workforce, unfortunately, has had significant declines in the United States, and so we're already working from a disadvantage, and then you're really pulling people who have existing jobs in areas from everything from, you can imagine, lead poisoning prevention to environmental health to chronic disease prevention, and you're pulling people who have day-to-day tasks all to focus in on communicable disease control and the pandemic response, and it's very difficult to sort of backfill. And so I think there is a workforce challenge in the US public health community that we need to fix there. In terms of just-in-time training, I think a lot of communities have tried to do that as well. And I think for some tasks like contact tracing, that is possible, but that is not going to, just-in-time sort of replace a lot of the technical skills that you need the public health workforce to have. So I think the solution here, at least on the US side, is we need to build the public health workforce. We also need to identify what are those things where, whether it's community health workers or others in the community, you can do some just-in-time training for and ensure that they're part of the public health response as well.
Are there others that would like to share their state's experiences in gearing up? You can put it in the chat and we can unmute you. Well, I can share some of what happened here in Connecticut. The state geared up very quickly to have a medical reserve corps consisted of nurses primarily, but other healthcare providers. And we were all volunteers, and we were asked to submit our credentials and so forth into a database. And I do get calls occasionally to come and volunteer, as does one of my neighbors who also happens to be a nurse. And so that's one way we've been able to do the vaccine. Some of our community health centers have been incredibly effective in gathering and reorganizing in order to meet the needs of the community, both in terms of how they quickly restructured so that they didn't skip a beat with all of their other patients. They probably skipped a lot of sleep, but they didn't skip out on caring for the patients that they usually cared for. One thing we did find, and this is held up across the country, is that there has been a lack of attention to preventive services during this time. So there is a backlog, and we're seeing some of the effects of that in relation to what's happening regarding breast cancer, for example, because mammographies weren't done for numbers of months.
Yeah, that's a great point, Shirley. The Medical Reserve Corps, which are in communities across the country, have really been able to stand up and support. And those are, in many cases, individuals who have training and different credentials already. So there are some structures like that are ready to go in various communities across the country.
Go ahead, Ms. Jelinas.
My second question is completely different. Again, I'm curious to see how a public health agency in the states are funded, as in, do they get a global budget and decide how much money will go to maternal child health, how much money will go to preventative services, how much money will go to childhood vaccination, or do they get funded by programs, as in, you get that much money for childhood vaccinations, you get that much money for preventative services? You know where I'm going? Just how things work.
Yeah, that's a great question, and it's somewhat all of the above, and that is part of the problem as well. There's so much siloed funding. A great deal of funding that comes to local health departments, state health departments, comes from the federal government. And agencies like CDC or others, and many of those streams are very focused on a particular area, as you just mentioned, and so then that also then at the local and state level filters down and builds silos there. And you can imagine in health departments, you end up having a bunch of then sort of competing, if you will, or siloed different program areas. Certainly, localities through taxes and fees contribute to financing health departments at the state level. Certainly there's some dollars there, but the lion's share of funding is through the federal government. And while some streams are somewhat flexible, many of them are focused in each of the categorical areas that you mentioned. And so one of the recommendations I think that you heard from the BPC is you need, not something necessarily open-ended, but you need a fund that can support just the building blocks, those foundational capabilities, whether you're trying to ensure environmental health, or whether you're trying to prevent communicable diseases, or you're trying to prevent chronic diseases. The foundational capabilities need to be strong, and there hasn't been long-term sustainable investment in those foundational capabilities. Instead, we have all these sort of categorical funding streams, which may not be the best way to support public health in the long term.
Would any of our other states like to respond about how their budgets are constructed for their public health functions? We have a couple of states represented here: Vermont, New Hampshire, New Jersey. We can unmute you. Just raise your hand and we can do that.
Shirley, I've got a somewhat separate question. It's Dylan, but I just wanted to ask it while we've got a little time here for Q&A. I was working for the Delaware State Senate as recently as June and July, and I know we talked a lot about access to primary care. And while it doesn't, you talk a lot about workforce in public health, but I'm just wondering in the far-flung future, if you see more opportunities for cooperation. I don't want to get into like too heavy-handed big government, but I know that we've started to subsidize, for example, through scholarships and grants, just the cost of going to school. If we can get those folks into the primary care workforce, I'm wondering if further down the road, there might not be more opportunities to kind of draw connections between public health as we see it today and what the future of primary care is going to look like. And I also think about that in terms of communicating everything, up to and including vaccines, and vaccine efficacy, is that, sometimes it can be hard if you're the CDC, if you're, Dr. Fauci on MSNBC in the middle of the day, or the CDC on God knows what, Facebook or whatever, to say, oh, trust me, it works. Where I think in the past, if we had more people with more primary physicians, it was probably easier to communicate then, oh, well, here's how this works. Here's, why it's safe. Here's where it might be effective. So I'm just wondering what the future of that might look like as somebody who looks constantly to the future and how things are evolving.
That's fascinating that you should be talking about that, because I was doing that last night with the Connecticut's task force on primary care. And then Dr. Brick and I were just talking about that earlier about how the health of the public and primary care are so integrally involved. Dr. Brick, you want to say something about that?
Well, Dylan, that's such an important question, and I do have to put a disclaimer out there that I am by background a primary care physician, and we're actually writing an op-ed on this very topic, that the way out of this pandemic is essentially better collaborations between public health and primary care. I'll tell you, but primary care in so many ways is sort of a cousin of public health. Public health focuses on population health, primary care on individual health, but this is the other area in our healthcare system. I talked about public health in less than 3% of the dollars. Only about 5 to 7% of healthcare dollars go to primary care, and that's about half what other OECD countries spend. So they spend closer to about 10 or 12%. We spend only about 5 to 7%. Primary care is the only healthcare service that will improve quality, improve outcomes, and reduce preventable healthcare costs all at the same time. And there's nothing else. And about 50 years ago, about half of clinicians were primary care. That has now dropped to about a third. So we have workforce challenges, we have payment and reimbursement challenges, we have sort of day-to-day practice sort of challenges. But absolutely, I think when you talk about whether it's the future of public health, the future of health here, we need a strengthened primary care system. Everyone needs a primary care clinician. So much of what we face in terms of the disease burden in this country is preventable. And it's going to be a robust public health system from the population side, plus a robust primary care system, primary care piece on the healthcare side. That's the only way we're going to be able to, whether it's a pandemic or whether it's during usual times, that we're going to really be able to optimize health outcomes and reduce preventable healthcare costs. So I think that's a really fruitful area for further discussion and really getting policymakers to really elevate sort of two sides of a very important coin if you care about health in this country, which are public health and primary care.
And there are some interesting things going on in some of our states. I know Maine has a fund to provide monies for tuition for people who are going into primary care, for physicians, nurses as well. I believe it's nurse practitioners. So there are pockets of that going on across states. But given the theme that one of our of this conference is about the collaboration and the sharing among states, I think there's wonderful opportunities for all of our states to get together, because a lot of people don't always stay in the state in which they're trained. So how do we do that? How do we share the wealth of our resources? So something for us to talk about. And I think that integration and what state policymakers, what role they have in strengthening primary care and public health together is really a very important discussion and not an easy solution, given the forces of the major players in the industry. We've all seen consolidation of healthcare services. So there's some real challenges, and state government has a very large role to play in those regulatory processes and the licensure processes with both the workforce and the structure and the payment of the system. So there's great opportunities for us to work together to do these things. We just have a couple minutes left. One of the things, we'd also all like to see a copy of your op-ed, Dr. Parekh. So if you can send it, we could even post it on the CSG website if that's all right with whoever's publishing it. But one thing I'd like to say before closing is for those of you on this call and get the messages back to your colleagues, if there are things that CSG East can do or I can do, and collaborations with any of the people that we've had talking with you over the course of the last several days, please don't hesitate to get in touch and let us know what the needs are at the state level and what we can do to help support you in addressing some of these really challenging issues. I'd like to thank Dr. Parekh. I'm sorry we can't have a big applaud. And I don't see my option to, I just see my option to raise my hand, not to be able to applaud on this, but thank you so very much for joining us. I would love for us to continue collaborating with you and working with all of our states and the members to really move some of these issues that you've raised today forward. So thank you so much.
Thanks, Shirley. Thanks for the invitation. Thanks for what you all are doing. And again, thanks for everybody participating today, and thanks for your public service.
All right, we'll be in touch. Thank you, everyone.
Thank you.
Thank you.